speaker. I'd like to introduce Dr. Sara Humphrey. She's joining us today all the way from up north, and she's going to be doing a session on brain health and preventing well. So thank you, Sara.
Hello, everybody. Oh, I got the hard bit following Wendy, didn't I? OK, so I'm just going to share some slides and then because I'm going to just run the pace of them. So just one sec while I get those up. I hope this works.
Thank you, Sara. We can see them on screen. Thank you.
OK, lovely. So it does mean I can't see you guys, but I understand that somebody's looking in the chat box and the question box, so we can have a look at that afterwards. Yeah. So I'm going to talk about brain health and preventing well, so sort of a different end of the spectrum to what we've been talking about already. I'm Dr. Sara Humphrey. I'm a GP by background. I'm the clinical lead for Yorkshire and Humber Clinical Network. And that's where I met some of your lovely colleagues who asked me to come today. Those are my interests, just in case anybody wants to look at those afterwards. So I'm going to start off with a little bit of data, because I love data for setting a context. So just going to tell you a little bit about what I know about the data. So you did see some up-to-date data from Colin, but roughly 9,500,000 people are living in the UK with dementia at the moment. That has gone down during COVID. That will go to up to more than 1 million by 2030 and more than 1.6 million by 2050. So numbers are increasing. Registers roughly increase by about 200,000 a year. OK, but what you do need to remember is, unfortunately, we lose between 15 and 20% of our patients living with dementia each year. Out our risks in the future, because this is all about brain health and risk. 25% of men, roughly, and 35% of women born in 2015 will develop dementia in their lifetime. So it is a significant risk. Risk goes up with age. So 1 in 14 people over 65 will develop dementia. If you live to over 80, that goes up to 1 in 6. So it goes up with age. A risk of a woman developing dementia at 60 is double their risk of breast cancer. So it's a significant risk, but we probably don't talk about that risk and what we can do about it enough. Wendy was talking about this thing, and this is the well pathway for dementia. And I'm talking about the first bit, which is preventing well. And we have I statements for this. I was given information about reducing my personal risk of getting dementia, and that's what we're going to focus on. What can we do to reduce the risk of developing dementia? So I'm going to talk about 4 bits. I'm going to talk about primary brain health. I'm going to talk about other risk factors that we know about, some of which we can, some of which we can't do things about. I'm going to talk about mild cognitive impairment, and then I'm going to talk about the interface with delirium and dementia. Good primary prevention, brain health. And some of you will have heard of brain health clinics that are popping up around the country that bring into this concept of prevention. And the main thing, if you don't go away and think about anything else, is what is good for the heart is good for the brain. But what we do is we talk about hearts. We like talking about hearts. We don't talk about brains with people. We don't empower people to know about their risk. It's almost like we hide dementia away. So here again, some more factors. About 1/3 of people's personal risk of developing Alzheimer's it may be due to modifiable risk factors, things we can do something about. Lifestyle changes improve cardiovascular health, can also reduce the risk of dementia. And the sources of this evidence is down on the screen for you. The incidence of dementia in the UK has actually fallen in male groups within the last few decades as we have improved their cardiovascular health. So we know it works. One of your kind colleagues, Paula, sent me some information about you guys in Gloucester. So you actually seem like Gloucestershire is a pretty healthy county, really. It has lower lifestyle risk factors than the average, or sitting on the average, but you do have a background of higher than average older, over 65 population, and you do have some pockets of quite significant deprivation. I'm also going to show you later about your risk, your numbers around other cardiovascular disease, but these are the sort of risk factors, primary prevention stuff. Studies show that dementia risk is lowest in people who have several healthy behaviours in midlife. Now, I'm one of these, and I bet lots of you are, people sitting between 40 and 65. And these behaviours include mental, physical and social activity, not smoking, drinking only in moderation, and having a healthy diet. The risk of dementia is lowest in people who have at least 3 of these behaviours. If we're doing just well in 1 or 2 of them, it does reduce risk, but not by a very small amount. So saying I don't smoke, I'm all right, is actually not the full story. Now, I've put what works. And what I really mean here, there's 2 things. What are the opportunities to do something to reduce those modifiable risk factors, and where does it work? So making every contact count. I still meet people who haven't heard of this. This is about teamwork. This means primary prevention is not one person's job in the practice or in medical profession, in the NHS. It's everybody's problem. If everybody makes every contact count, every time you meet a patient or have a contact to do some prevention work, that's what works. And there's some really good resources on e-learning for health. There's a toolkit, there's e-learning if you've got social prescribers or people who haven't heard of making every contact count. The second thing we know about what works is very brief interventions. We can always think that we don't really have time to do it, but actually brief interventions, very brief interventions work, backed up by NICE. So there's the evidence of what works. The opportunities lie, and if there are GPs on the call, which I know there are, the dreaded NHS health check is an opportunity, all right, to remind people about good brain health. Social prescribers are an emerging new opportunity, an asset for primary prevention, especially when we're thinking about that every contact counts. There's a really interesting paper that I'm putting on here that you might want to have a look at, which looks at why we don't do it. Okay, and it's difficult, I think it's complicated. Healthcare professionals' barriers and enablers to providing opportunistic behaviour interventions during routine medical consultations. It's a really great paper to have a look at as a practice because it'll go through the barriers and enablers, because they're all individual to every practice, okay? So it can be a really good way of really looking at why don't we do it and why can't we do it? So those are just some thoughts there about primary prevention. So reducing the risks to the heart and brain. So just again, some more facts here. 50-odd% of people living with dementia also have hypertension. Virtually everybody, over 92% of people with dementia have another healthcare condition, and a third of them will have 2 or 3. So that means that you're managing other health conditions and dementia. There's some figures at the bottom there. Sorry, they're a bit small, but basically you've got slightly higher than average QOF registers for ischemic heart disease, stroke, hypertension, and slightly less than average of diabetes. So you do have a population of people who have significant cardiovascular risk factors and problems with their heart health. The main cardiovascular risk factors that are known to increase a person's risk of dementia are high blood pressure, stiffening of the arteries, atherosclerosis, raised cholesterol, being overweight and obese, being physically unfit, and type 2 diabetes. These risk factors are more strongly linked with what we call vascular dementia, because that's caused by problems of blood supply to the brain, but they're also increase a person's risk of developing Alzheimer's, the other major type of dementia, and there are others. This isn't a talk about the types of dementia per se. These factors start to have an effect during a person's midlife. Again, 40 to 65-year-olds, a lot of the people sitting in this room. And it also increases your risk of developing dementia in later life. Type 2 diabetes is an important risk factor for people, even if it starts later on. So take home point number 1. What is good for the heart is good for the head. And we need to share that with patients. About a third of people with Alzheimer's disease might have potentially be attributable to potentially modifiable risk factors, and a 20% reduction in risk factors per decade would reduce our prevalence in the UK by 300,000 cases by 2050. So we could have a very powerful effect. What else increases risk? Hearing loss. Dementia is more common in people who've developed hearing loss in this midlife time period. We don't quite know why. It may be because people withdraw from social situations and become more isolated. That reduces their cognitive reserve, and I'll talk about cognitive reserve later. It may be that by straining to hear things, other bits of your brain doesn't work properly, and it may be the same diseases that cause dementia also affect hearing. So studies have shown that using hearing aids may significantly reduce a person's risk of dementia. And so having regular hearing tests and reminding of people of that, and I think that's quite important over COVID, if people haven't recognised maybe that they're with other people and their hearing is getting poorer. It's not the hearing aid, it's the improvement in hearing that reduces somebody's risk. Depression. People who have depression in their life also are at higher risk of developing dementia. And this is maybe because depression is a harmful long-term effect on the brain and the way people think and also cope with difficulties and that cognitive reserve, doing new things. It's not clear yet if it's treating somebody's depression with antidepressants will reduce their risk, but preventing it from happening in the first place is very likely to help. I couldn't miss this opportunity to put in 2 slides about depression in older people, because I think it's often missed. It doesn't present in the same way as it does for younger people. And I'm going to show you 2 slides that you can, second slide, you can go away and use as a resource. And the main risk factors are people living alone, people who are bereaved, people who are carers, people who drink alcohol, people who come to you with low energy, and people also with frailty and physical illness. Apologies for my husband there. And the next one is general reaction. There's this thing called counter transfer. When people make you feel frustrated all the time in consultations, please think, is this because they could actually be depressed? This slide sums up on one page how you might think about risk factors, how you might screen for depression, what assessment scales you might use. I know in general practice we use the PHQ-9, but the geriatric depression scale is great, and I use that a lot. And then there's a little treatment algorithm there for treating people with depression that again works. So a good little resource if you ever want to have that. We have it on a template in Bradford, but you can have that on your wall of your consulting room. Wendy mentioned young onset, and obviously that's dear to her heart because of what's happened to her. And I just wanted to put in one slide around young onset dementia. Dementia is considered young onset when it affects people under 65, sometimes called early onset or working age dementia. It is more rare and it is often more difficult to recognise. People are often more reluctant to come forward and may put off visiting primary care. Awareness of the condition, though, is generally low within GPs and primary care, and a lot is being done to try and address that. And often we put down symptoms due to stress or depression, but the converse is stress and depression often cause symptoms of fuzzy brains, not remembering things. So it's a really difficult area. And what I tend to say to people is it doesn't feel right and the person is not improving with antidepressants and they're not, you're not treating it and it's not changing the way you'd expect. Think about early referrals to memory services. There is a Young Dementia Network, and they've got some webinars coming up very soon, a whole session on diagnosing young onset. Okay, so I just thought I'd put that in now while I had an opportunity. Cognitive reserve. Cognitive reserve is this ability of the brain to cope with disease. Okay, we build up our cognitive reserve throughout our early life. And what it's felt is that cognitive reserve means that when we have a cognitive decline, symptoms develop and show themselves later in our life. So the things that reduce our cognitive reserve are leaving education early, having a less complex job, and being socially isolated. So obviously we can't reduce our risk knowingly in middle age of building up that reserve, because it's all happened in early adulthood and childhood, how we do with education, etc. But we can increase our cognitive reserve in later life by staying mentally and socially active and reducing social isolation, because they keep the brain's reserves going. There's loads we could talk about here, but what I thought you could go away and have a look at is some really great resources that I put together on a single page that you can use and send to patients, share with patients about how because people often ask, what can I do? There's some really practical tips here from a lot of our third sector organisations on improving your brain cognitive reserve, reducing your risks. I put traumatic brain injuries in. I know we can't reduce these, but they are a significant risk factor for dementia. And a lot of you will have heard on the news last week the papers coming out of Glasgow University about rugby players and traumatic brain injuries and risks of neurodegenerative diseases, and dementia was one of them. I think it's as a medical profession, we're not going to stop people playing sport, but actually knowing that some of the sports that people are doing and contact sports with head injuries may affect somebody's risk of dementia, I suspect it's going to change how sport is played. But it's also, for me, it's recognising, especially with young onset, that dementia could be happening, and to think about history taking, because you can't prevent it having happened, but you can refer early if you think you suspect it's happened. So take home point number 2. Depression and social isolation and loneliness are often missed. We don't ask enough, and if we don't ask, we'll never know. If we know, we can use those assets like social prescribers to change the social isolation, think about depression and reduce loneliness. Mild cognitive impairment, and does it increase risk? So mild cognitive impairment is basically age is associated with cognitive decline, and at some point people have a demonstrable cognitive impairment without actually crossing the threshold into dementia. So it's sort of like a pre-stage. People with mild cognitive impairment have an increased risk of developing Alzheimer's disease, especially Alzheimer's disease, but all dementias. What we know is 10 to 15% of people with mild cognitive impairment will progress to Alzheimer's disease each year. So that's roughly 50% in 5 years. If that's what you just need to remember. But it's worth remembering, and it's worth sharing with people with mild cognitive impairment, is that some people will progress to dementia, some people will stay stable, some people will improve, and some people who do return to normal will then go on and develop dementia. So they're a group of people that need to be closely monitored. So your system needs to have a way of monitoring those people so that they know early those people that do progress, but also invest in brain health for people with mild cognitive impairment. And think about that brain health to help reduce their future risk. And there's something else I'll tell you about in a moment. And that's it. Why is it important? Well, lots of you will have seen in the news that there are new phase 3 trials that have just shown our first potentially disease-modifying drug for dementia called lecanemab. it's likely that it will have a license very soon. And if it is, it will then go through NICE. And if it is endorsed by them, that will increase dramatically the number of people coming to you, the demand for an earlier diagnosis and an accurate diagnosis between the difference between mild cognitive impairment and Alzheimer's disease. So that will increase scanning and psychological assessments and demand. So that's why you need to think about that. And there's a link to the article in the Guardian that was publishing some of the results. So take home point number 3, demand for services and assessments will go up if we get disease modifying drugs, and pathways will need to be developed, or otherwise we will not be able to cope. So that's another thing for your area to think about. Delirium. Does delirium increase risk? So delirium is an acute brain failure, often confused in hospital. Often people are labelled wrongly as having dementia when actually they have a delirium. They have an acute sudden onset impairment, which usually resolves fairly quickly, but can take several weeks. Why do people get it? Go back to that cerebral reserves. Our cerebral reserves, the red line, get less as we get older. So it doesn't take much for them to dip below the level where confusion becomes apparent. Recent studies have suggested that delirium is associated with a greater risk of developing dementia, but also accelerates the decline in people with existing dementia. So the more acute onslaughts of delirium you have to your brain, the worse the outcome. So preventing delirium is not only important in preventing dementia, but also in preventing decline. I could do a whole hour on delirium, so I'm going to just put this one slide and I'll send through a link to this resource, because I don't think I put it on the slide, called Think Delirium, how to prevent it, suspect it and stop it. And people often think delirium is due to some really complex reason, and the answer is mostly it's not. It's really simple stuff that we can look at in primary care. What's difficult is sometimes managing the distress of the person with delirium. But I won't say much more about that. Anticholinergic medicines and the risks of delirium and reducing that cognitive reserve. This is really important because I think there's less known, or we're generally not as good at recognising anticholinergic burden as we could be. Anticholinergic drugs basically are used all over the place for things like allergies, COPD, depression, incontinence, Parkinson's disease. And these drugs are great for those things, but build up their anticholinergic properties. And those are dizziness, confusion, falls, and they're additive. So the more drugs you take with an anticholinergic burden, the greater the effect it has. So there are scales that you can use to add them up, and you'll be surprised at some of the drugs on there that you wouldn't have even thought had an anticholinergic burden, but they do. So you can either use one of the agingbrain.org and have a look at them, or my new favourite thing is using the ACB calculator score online, where you put in the drugs and it tells you what the score is. And here was an example. So somebody was on amitriptyline, tolterodine and codeine, and they had a risk score of 7, which is a high risk score of death, confusion and falls, so delirium. So my take home point number 4 is think about anticholinergic burden. It's often overlooked, but very easy to do. And it's a real opportunity to think deprescribing. You can always start drugs if you need them again. And it reduces that risk of delirium, but also helps somebody's brain reserves, cognitive reserves. So finally, 1 in 3 people, cases of dementia could be prevented by addressing those modifiable factors that we've talked about. I am available on email. I do get loads, but please do contact me if you're interested in anything. And I'm now going to stop sharing so you can ask any questions if you want to, and I hope I've been on time there.
Spot on time. Thank you so much, Sarah. That was excellent. Real, yeah, good summary and information around brain health, particularly, and reducing your risk of some of the dementias. So it's really good to sort of cover those different aspects today. So thank you very much. I don't think there are any questions in the Q&A section related to your presentation. But huge thank you. There's a couple of well done's and fantastic presentation in the comments. So thank you. And you're also hanging around for the Q&A panel